Okay, Dr. Hasib, I have started the recording. Yesterday we forgot. Okay, this is the book that is Smart BT. Here you will get communication scenarios, your clinical station scenarios. Okay, all have this book with them?
Yes.
Yes, all right. So when yesterday I presented the topic that was JIA, it's page number 349. This one. Okay. Now see here. These two topics, they are extremely important for your musculoskeletal system. One is that your hypermobility. This section, like this question, you may get for your video stations, your clinical stations, and your clinical examination, right? The next topic here is the GIA. From the this is basically a station. This is basically for your history stations. Why? See here, when you give a read to this these pages, you will see they have told you there is in the UK there are very few patients with typical physical sign and symptoms of this GIA. They do not present there with the deformities, but here in Pakistan and other countries, we can get this in the clinical examination too. GIA in the UK, that is usually a history station, while other countries with the deformities, this may be a clinical station too. This hypermobility, that is definitely that is a benign. In the hypermobility, you will get 2 or 3 scenarios. In the Pakistan or in other countries, benign hypermobility may be in the clinical station too. Okay, so give a reading to this book before going to present any case, any clinical station, any video station, or any of your history stations. Today we will discuss about this JIA. Okay, please open your books if you do have this one with you. Just 1 minute so that I can tell you what are the important points you must read from here. Yeah. 349. Okay, so this is the topic that is the GIA. All right, whenever they will give you a scenario of any child coming to you with the limping gait, any point, key point that is pointing towards a GIA, like in the last scenario, we had a key point that was there was morning stiffness that was present. Okay, you must know what is the criteria for diagnosing any case that is GIA. So Dr. Mariam, can you please tell me what is criteria for this GIA diagnosis? Mariam, you
Yes,
can
ma'am.
yes.
Age of onset less than 16 years.
Yeah.
Disease duration for a minimum of 6 weeks.
Okay.
And arthritis in one or more joints defined as swelling or effusion, or the presence of two or more of the following signs. Limitation of
Yeah.
range of motions, tenderness or pain on movement, increased heat.
Okay. All right. So this is the criteria. In this criteria, Dr. Mahdia, see there is age. The age of the patient should be less than 16 years and duration of disease that was 6 weeks. What was the duration of disease in our patient yesterday? That was 4 months.
Oh,
So it's more
4
than
months.
6. Okay. Yeah. Any sign of the arthritis? See here, please do remember arthritis. Yeah, we all always like we had remember inflammation. There must be some tenderness, there must be swelling, there must be increase in the temperature. Do remember, any child with the arthritis can come to you with only and only effusion. So any child coming to me with the joint swelling and with all other signs of this inflammation, that is the case of arthritis. Okay, so whenever any child is coming to you with this limping gait and involvement of the joint, in the yesterday's history, you have to make a diagnosis. Is that polyarticular? Is that oligoarticular? Or is that systemic onset GIA? Now see here. Why I am reading this one? I know you all have cleared your theory exam and you have like a grip on this topic and other things. But yes, I just wanted to tell you why we're asking some question in the history to make our diagnosis. See here, yesterday, like, had we any categorization of the polyarticular JI yesterday? Yes, we decided on the basis on the involvement of the joint. How many joints are involved? Sometimes they will give you a patient who is having oligoarticular, like less than 4 joints. Any patient who is with a more than 4 joints, sorry, 5 joints are like more than 5 joints, that is polyarticular. Okay, see here the best candidate who is able to tell this patient who is coming to me, yeah, this is a polyarticular, his 6 joints they are involved, this definitely a case of polyarticular. You have to decide even on clinical or on your history, is that rheumatoid factor positive or is that rheumatoid factor negative? Okay, so what clinical sign our history questions will tell you this is a case, this is polyarticular JIA, but it's rheumatoid factor positive, and who are rheumatoid factor negative. So, Dr. Mariam, any point here? We are just right now talking about this polyarticular. So, Dr. Mariam, what are the points which are favoring this is a case of rheumatoid factor positive JIA?
Ma'am, if a patient
Yeah.
has uveitis,
Uveitis? No, not at all.
rash,
They do not have no. Okay. The next one. Rheumatoid factor. See, this is a sign of poor prognosis. Any child who is not well, number 1 point, whose disease has progressed very rapidly. Okay, and any patient coming to you with the deformities, you will consider this patient has 6 joints involvement. This is, you will categorize, yes, that is a polyarticular. I have decided polyarticular. His disease has progressed just within 4 months. Now see here, in the John's mother told John was all right 4 months before. Okay, he developed involvement of both knee joints, these joints of the small joints of the hand, and also the temporomandibular joint. So within 4 months, patients has multiple joint involvement, and in that case, if any joint abnormality is present, rheumatoid nodules they are present. If mother was saying, yes doctor, I can feel a lump on his elbow joint after the all these problems, it means she's telling you about the rheumatoid nodule. Okay, this is most likely a clinically rheumatoid factor positive polyarticular GIA. Okay, in the patients of the polyarticular GIA, they are not having any uveitis. Uveitis that is positive, that is associated usually in the oligoarticular who are ANA positive. It's not the rheumatoid factor positivity which will tell you that this patient is more prone to the uveitis. Okay, so in the history or in the clinical examination, first of all, you will decide, is this a case of polyarticular or is this a case of oligoarticular or is this a case of systemic onset GIA? Okay, so number of joints they are present, it's poly or oligo. There is involvement of the systemic disease. This is the third type of the GIA. So for the systemic disease, what we have seen, there is presence of the fever and the systemic sign and symptoms. So fever is a one systemic sign. Okay, was John systemic onset GIA yesterday? Dr. Nimra, was that a systemic onset GIA?
no, ma'am.
No. Why no?
No, it was not systemic onset. There was no symptoms like any rash or
Okay. Now,
fever.
in the examination, in front of the examiner, you would say, no, that was very less likely. There was no fever. Number 1 point. Okay. What is the second point?
Also, there was no rash.
There was no rash. Okay. There was no lump and bumps, no lymphadenopathy. There was not increase in the tummy size. It means there is no hepatosplenomegaly. Serositis. Patient was not having any problem in difficulty in breathing. Like there was not pleuritis, there was not pericarditis. So there is not any feature that was suggestive of systemic onset GIA. Okay, so we have decided this was a polyarticular. In the polyarticular, next we have to decide that was rheumatoid factor positive or negative. Was John rheumatoid factor positive or negative? What we presented yesterday? Most likely that was rheumatoid factor negative. Yeah, there is rapid progression, but we couldn't find any rheumatoid nodule on the history in our patient. Okay, the important points, these 1, 2, 3, 4, 5 things you must know at least when you are coming for the exam. You must know, you must cram, you must memorize what is written in this book. It's very comprehensive, short, and for Viva, that is very important. For your Viva preparation, mark BT and your Reham's notes, like they are enough for that. Okay, so next we have decided that is polyarticular. We have decided this rheumatoid factor negativity. Examiner may ask you, what is the percentage of the patients who are coming to you with the GIA, how they are divided? So it's some Viva questions, you must memorize that. So can anybody tell me what is the percentage? How many are presenting with the oligoarticular? How many are presenting with this like other? Dr. Hasib, can you please tell me? Okay. Okay, so please make a chart like this or see here. If I write it like this is a case of GIA. 50% of the patient, they are with your oligoarticular. Okay, 50% are oligoarticular, right? 35%, sorry, 30% they are polyarticular. In the polyarticular, we will divide it as rheumatoid factor negative and rheumatoid factor positive. Okay, so luckily just 5% they are rheumatoid factor positive and 25% that is having good prognosis, they are 25% rheumatoid factor negative polyarticular JIA. The 10% of the patient, they are presenting with the systemic onset GIA, okay? And the 10% of the patients, they are presenting with enthesitis related arthritis, okay? Among these, if we talk about the sex predilection, this 10% are presenting with enthesitis, sorry, the boys are mostly presenting with this enthesitis relating arthritis, while the other of the candidates, they are usually girls, like it's more common in the girls. Okay, all right. Okay, write on your books just to memorize. Some examiner will ask you what is the percentage, and some examiner can also ask what is the prognosis of your patient. So you will decide on the basis of your clinical presentation in the history and examination, is that rheumatoid factor positive, is that rheumatoid factor negative. Okay, which one is most aggressive? Definitely this systemic onset GIA, that is most this is one of the worst diagnosis of the GIA. Why? Because this patient may come to you with the macrophage activation syndrome, that is the worst complication of any GIA. Okay, so the next we will read about polyarticular rheumatoid factor positive GIA. It's only the 5%, it's only in the girl, like 80% they are girl. Okay, rheumatoid factor that is positive in 100% and ANA is positive in 75% of the cases. You must read it out. HLA are force, just more aggressive force. So see here, if examiner asks you what are the prognostic factors, okay, so prognostic factors, number one, that is the genetic study. Next one is the rheumatoid factor positivity. Okay, see here, no uveitis, sacroiliitis, that is rare. Do remember, like Mariam told me, this is a rheumatoid factor positive and it's having uveitis. Do remember, rheumatoid factor positivity is patient, they will not have uveitis. Uveitis is usually present in the oligoarticular GIA, okay? And those are the patients who are ANA positive. ANA positivity, that is associated with the eye problems. Okay, that is associated with the eye problems. Okay, all right. Next, about the oligoarticular, I told you. Now the differentiating point, very different point you will read here in the oligoarticular JI. See here, the case present with swelling but often no pain. This is very important line. Why I told you, it's not all the signs of the inflammation they are present, like that is tender, that is hot, that is painful. No, not at all. Just effusion that is present in the joint. This is a case of the arthritis, and it happens is usually in cases of oligoarticular JIA. That is the most common type. 50% of the JIA patient will present with the oligoarticular JIA. They will present with the morning stiffness. They will present even without pain. They can have pain, but even without pain, they can come to you. Now see here, the more painful the joint, the more likely an alternate diagnosis. This is the line. This is the line. Very important. Okay. Then you must consider some other diagnosis. Okay, the more painful is the joint, the more likely is the diagnosis. What alternate diagnosis is coming into your mind when you think of excruciating pain in the large joint? Dr. Arifa?
Ma'am, rheumatic fever.
Yeah, that is rheumatic fever. Okay, what is the differentiating point between the rheumatic fever and juvenile idiopathic arthritis?
Ma'am, non-deformity in GIA
Yeah,
and
no, no,
no,
no.
no,
JIA.
no. Oh, yes. Sorry, ma'am. Oh, yes.
Yes, do tell me, please.
Non-deforming joint in rheumatic fever, while
Yeah.
in JIA, the joint will be deformed.
Okay, now see here, when patient is in the examination hall, she's sitting in front of you. Okay, this is the first episode. She has come to you just after 7 weeks. Can you see any deformed joint in case of GIA? It's very less likely, now. Like may present later
Yes,
on.
ma'am.
Okay, so one thing you told, yes, deforming and non-deforming. The other one, that is the excruciating pain. The third one, that is very important.
Alternating joint involvement.
Okay, that is
In
migratory
rheumatic-
arthritis. Yes. Number
Migratory, yes.
4. Please to remember, when the small joints of the finger or hands, they are involved, okay,
Okay.
it can never happen in your rheumatic heart disease. This is very important point, okay. Large joints involvement, that is a case of GIA. My second differential, that was SLE. My third differential, that may be Lyme disease. My fourth differential is this one, okay. Large joint and small joints, when they are involved, we will think of GIA, SLE, what I have told you. But if only and only large joints, like your ankle joint, your knee joint, that is involved, this may be a case of rheumatic heart disease. A simple line is that in the rheumatic heart disease, small joints are not involved. Okay. All other features, yes. But clinic, why we go in the PGALs for screening of the GIA? Squeezing of the hand is one of the step of the PGALs. Squeezing of the hand, like we are confirming there is no involvement of the small joints. When there is involvement of the small joints, we will think of GIA and all the diagnoses I told you. In the rheumatic heart disease, small joints are not involved. Okay. Okay. So next, about the GIA, I told you oligoarticular ANA positivity, uveitis. We will screen for that. There is time duration. Every 6 months, you have to go for the slit lamp examination for screening out uveitis. This is because that is painless. In the uveitis, there is no pain, and patient may present with the blindness if the monthly screening, 6-monthly screening is not done. Okay. Now, next is the hip involvement at presentation is very, very rare and should prompt us alternate diagnosis. Okay, complication. Now see here, in the complication that is of oligoarticular, they have talked about the chronic uveitis. 30% asymptomatic can cause blindness. Slit lamp examination, if EN is positivity, it correlates with the risk of the uveitis. Usually their blood tests, ESR, rheumatoid factor, they are normal, right? So why this line is important? Do remember, in case of rheumatic heart disease, we check the activity marker sorry, by this ESR and CRP. Okay, and here in this case here they are talking about if in the chronic uveitis, though disease is active, but ESR is normal, rheumatoid factor is also normal. Okay, active disease is treated with the steroid eye drops and mydriatics, right? What is the prognosis? This is one of the Viva question you must know. It resolves within 6 months. Approximately 20% of children. For this, you will also give a read to this Reham's notes. He has also written in a very good way about this prognosis. Who initially do well will have a recurrence, most commonly within the first year of the life. Polyarthritis develops eventually in 20% of the cases. These children are not reclassified as having polyarticular arthritis. So, can anyone tell me what is extended oligoarticular and what is persistent oligoarticular? What is persistent and what is extended oligoarticular joint? Dr. Arifa? Okay, see here. We have decided for the JIA criteria, its duration that is 6 weeks. 6 weeks duration. My joint involvement that was 3. Okay. Then I will see over a period of 6 months. Okay. What happens in the extended and what happens in oligoarticular JIA? In extended oligoarticular, initially it was less than 4 joints involvement. So I have decided this is a case of oligoarticular. Okay. Over a period of 6 months, I have seen just 3 joints are involved, just 4 joints they are involved. I have labeled this is a case of oligoarticular. This is a case of persistent oligoarticular. It started as oligoarticular and it remained over a period of 6 months oligoarticular. Okay. The next case, this is a patient B who within the 6 weeks whose 3 joints they were involved. Okay, this patient is coming to me for the follow-up over a period of 6 months, but after the 6 weeks his joint involvement that may be 7, it's more than 5, but it's not a case of polyarticular. Why? My criteria was decided within 6 weeks. Over a period of 6 weeks, it was oligo. Yes, that is oligo. Whenever it is coming to me, that is oligo. But now the number of the joint involved, that is more. This is called as extended oligoarticular. Okay, Dr. Mehdia? This is called extended oligoarticular. So while taking this history, keep these basic points in your mind, right? So yesterday, Dr. Mehdia gave us one of the differential that was infections, but she didn't tell us about what type of the infection she is talking about. See here, here in this case, they have told us about the infections, but that is one of the differential of the systemic onset JIA. Okay, systemic onset JIA where fever was present. In our case, fever was not present, so we cannot put infection in our differentials yesterday. Malignancy, yeah, that is coming with the fever and with the sickness, so we cannot put malignancy in our differential of the JIA. Okay. SLE may come to you with the fever, without fever. So it is coming in the differential of both. And other thing is that in case of SLE, we have serositis that is coming to us with the pulmonary problems, difficulty in breathing, and cardiac problems. Okay, so this is the basic concept. Is that clear? Clear, Dr. Mehdia? Okay. All right. So management of the yesterday when I asked about the management, Dr. Mehdia, you will read it from here and I will show you from Riham's notes if that is yes. See here, here he or she, I don't know, he has written it. This is the management plan. You will tell in the examination hall just like this. You can make your own notes, write it down. There is, I will decide on the patient presentation, is that like sick child or not sick child. I will admit or I will treat this patient on OPD basis. Okay. In the OPD basis, there is the team that is present, non-medical management, medical management. And this is the question. Even if you read the book Nelson, here they have the first line in the management that is given, what is the goal of the treatment in the GIA? This is one of the favorite Viva questions. It's not the management. What is the goal of the management? And in the goal of the management, here they also have written, this is a basic point, optimal nutrition. Okay. See here, goal of treatment in the GIA. I am reading from the last paragraph. Switch off the inflammation. Okay, like relief of the pain, prevent permanent damage, maintain function, and prevent deformity. Treatment of the complications like eye affection, infections. Ensure optimal nutrition. This is one of the basic management goal. And you will read it, you write it in your history. You will definitely ask very specifically for the nutrition. Rehabilitation by the help of the team, psychological support group, and you will also give support therapy to the patients, like the mothers who are having the kids with this GIA who are thriving well. This is called support group. And this support group, support therapy, you will also advise to the patient if that is coming to you in the exam. Okay. Okay. All right. So this was the management. Here they have written in the form of drugs and in the form of the non-pharmacological therapy. But in the examination, you will not present like they have written here. You will present it like it has been written in Reham's notes. I will admit the patient. I will maintain IV line. I will involve multidisciplinary team involving myself, school nurse, school teachers, support therapy, psychological therapies, and all these things. But what we discussed yesterday. Okay. Okay, all right. And you will also know what are the side effects. See, yesterday, if I talked about what is the side effects, it's not like hepatitis, hepatotoxicity. Your answer should be like this. It would depend which type of the drug that is being given. Ectemra is most likely used. You must know the side effects of this interleukin 1 inhibitor and interleukin 16 inhibitors. That is tocilizumab and one is anakinra. Okay. Give a reading, memorize the side effect of at least 3 or 4 biological agents and these disease modifying anti-rheumatic drugs. Okay. Okay. All right. Now I will show you some slides, some pictures for the GIA patients. Okay. Okay. Dr. Arifa, Dr. Mariam, Dr. Hasib, can you please tell me what is this? Is this clear? So let us try, as this patient is standing in front of me. This is the right side and this is the left side. Okay. Which one is having problem? Okay. So Dr. Hasib is saying that is the left ankle side. Okay. See here. Is this ankle involvement or something else? This is tendon involvement. This is the ankle. This is ankle. This is ankle. Okay. Now, yes, there may be involvement of the ankle, but where is the redness? Where is the inflammation? Now, compare this side. Yeah, this one. Okay, I can appreciate. But here is the loss of the contour on the ankle side, and there is redness more on the tendon side. So, tendon side that is red, that is inflamed, there is swelling around the ankle joint. Okay, is there, this is skin that is shiny, here the skin that is not shiny. So I have decided the left side that is affected. Okay, where is the problem in the muscle, or is the problem in the joint, or there is problem in the tendon? So most likely the problem is in the tendon. Why? At the point of insertion of the tendon, there is redness, there is signs of the inflammation. and there is swelling around the tendon and around the ankle joint. So what is your diagnosis? What is diagnosis? This is enthesitis related arthritis. Okay, this is arthritis that is due to inflammation of the tendon. This is called enthesitis related arthritis. What percentage is present? Now, in the examination, they can ask you, what is the percentage of the patient of the GIA coming with this condition? This is the 10% of the patient. Is that common in the girls or the boys? That is more common in the boys. Okay. Is there any association with any other autoimmune disease of this patient? It is associated with the inflammatory bowel diseases and ankylosing spondylitis. So how will you examine any child coming to you with the joint involvement? You must know I will go for PIGALS first, pediatric gait, arms, legs, and spine screening test. Okay? Clear? This picture is clear? Okay, all right. So, what is this sign?
Prayer sign.
Yeah, this is prayer sign. What is the diagnosis? What can you see in this picture?
Small joints of the hands
Small
are
joints.
involved.
Interphalangeal joints. This side or this side?
Right side.
Seems to be, see here, this joint seems also to be involved, but it is more on the right side. Okay, on the right side there is swelling, there is deformity of the interphalangeal joints. This is a prayer sign that is showing the involvement of the interphalangeal joint, more marked on the right side. There is also a little bit swelling on the left hand too, and on the right side there is also deformity. ठीक है, flexion contractures. What is your diagnosis? Is this a case of rheumatic heart disease? No, not at all. Small joints are involved. Is this a case of GIA? Yes, that may be a case of GIA. Is this a case of SLE? Yes, that may be a case of SLE. Okay. Is this rheumatoid factor positive or rheumatoid factor negative? For this, we will answer. For that, I will complete my examination. But here in this picture, there is deformity of the joint. So most likely this seems to be a rheumatoid factor positive GIA. Okay. Okay. This is the next picture. Okay, now who will describe this picture? Who is this iPhone, please? Unmute yourself and describe. Where is the abnormality? This side or this side? Where is the abnormality? Right side. Okay, so here is the abnormality. Okay, which joint? Is that ankle joint or is that knee joint? Is swelling. Okay, we will describe there is loss of contour on the right knee side. There is swelling on the right side, and what else? There is contracture, there is flexion. See here, this leg, the patient has straight leg, okay, placing the foot on the floor, but here there is flexion on the right knee side, cannot bear weight on the right side, and maybe there is flexion at the knee joint. Okay, so what is your diagnosis? What is your diagnosis? What is your diagnosis? Stop it. JIA. Okay, Dr. Arifa, just one joint is involved. See here, this may be a case of septic arthritis. No, not at all. Not enthesitis related arthritis. It's not the inflammation enthesitis related arthritis that usually comes with the involvement at the ankle tendon, this tendon, okay? It's not coming here. I can see there is problem in this joint, okay? So when a single joint that is involved, your first differential, though here there is no history that has not been written, okay, but if there are signs of inflammation, they are present. This is a case of joint infusion. This may be a case of septic arthritis. Why only one joint is involved? This is maybe a case of monoarticular involvement. This may be a case of oligoarticular JIA. When only and only one joint is involved, they have given you signs of the inflammation. This is the case of septic arthritis, number one. What is on the second? This may be a case of septic arthritis. My supervisor used to say any child coming with a single joint involvement, that is your knee joint, that may be hip joint, septic arthritis is your topmost diagnosis. No signs of inflammation, child is not having pain, child is not having fever, single joint is involvement. This may be a case of oligoarticular JIA. Okay, so we have to decide over a period of the 6 weeks, this is a case of JIA or this is a case of septic arthritis. Okay. So this is just the deformities in the candidates who are presenting from UK. They usually will not get these type of deformities. Okay. Now see here, there is swelling of the knee joint. There is valgus deformity. Okay. And the foot will not be on the floor. This is due to flexion contracture at the knee joint. This is the micrognathia, retrognathia due to involvement of the temporomandibular joint in case of JIA. Okay. So these are the deformities, small joints, they are involved. This is a case of fully articular JIA where all these deformities, they are present. This is a leg length. Usually we do not perform this leg length in case of Pregals. Why? See, like usually we do not have much time to measure for this leg length discrepancies, but yes, we must have an understanding how to check for leg length. I will show you from another book. Okay. So these are the deformities. This was the discussion about the JIA. Knee is swollen again for that. Okay. The next topic we will discuss today, that is about the hypermobility. Okay, what is hypermobility? This is from, you will also read it from your this MRCPCH. Hypermobility and Beighton score, that is extremely important. You may get this in your clinical station. You may get this especially for your video stations. Okay. So what is hypermobility? Many children, they are hypermobile, okay, and that is quite normal. The patient is not coming to you with a tall stature. The patient is not coming to you with the weight problems, increased weight, decreased weight, stature problem, but his joints are hypermobile. That may be a case of generalized joint hypermobility. That is a benign condition which is present, okay. So for that, you must know about this Beighton score. Okay, I will show you the diagrams like how to assess for that Beighton score. Any one of you here? I think Dr. Mariam, we also have discussed this Beighton score before. How to make a diagnosis of the generalized joint hypermobility? They will give you a scenario, a child who is just getting tired, who is having problem after running, after exercise, otherwise there is normal weight, there is no problem in the weight, there is no problem in the height, there are no contractures, he can put his foot flat on the ground, there is no deformity, there are no scars, there are no bruises, there are no skin laxity that is present. So but the joints, they are hypermobile and there is no skin laxity, no stitcher problem, you will make a diagnosis of the generalized benign hypermobility. Okay. Okay. Now see here, for this is the diagram that will show you how to assess for the Beighton score. What is the total number and what like how you will score your patient. These are the postures. Now, can you see? This is hypermobile. Can you like oppose your thumb to the forearm like this? Just one. Okay. Now see here. Let us start with the picture number 1. This is your fifth metacarpal, your small finger. Okay. Is that moving 90 degree or more than 90 degree? Okay. Put it here, or less than 90 degree. My little finger is going less than 90 degree. What about yours? So if hypermobility is that if the little finger, you can extend it beyond the 90 degree. Okay. Can the fifth finger be bent or lifted upwards at the knuckle to go back beyond 90 degree? So if can go beyond 90 degree, this is a case of hypermobility. Okay. If yes, add 1 point for each hand, 1 for right hand, 1 for left hand. Okay. All right. So the next point, we will start from the hand. You will place your hand like this and you will see the 90-degree angle for your little finger by bending it backwards. Okay. The next point, that is with the thumb, oppose your thumb to your forearm. Okay. Test both sides with the arm out straight, the palm facing down and the wrist then fully bent downwards. Can the thumb be pushed back to touch the forearm? If yes, add 1 point for the right and 1 for the left. You can do it by yourself too. Okay. The next thing about the elbow, straight, put your elbow straight. Okay. So what is this? This is the extension position of the elbow joint. If your elbow can be extended more than 10 degrees beyond the neutral position. Okay. So if you put it, that is, see here, if you can do it by yourself. Dr. Mariam, Dr. Nimra, are you doing it on yourself?
Yes, madam.
Yeah, definitely. We also has discussed this previously too. Okay, more than one extra 10 degrees, this is also 1 point for your each side. Okay, the same is the case with the extension of the this your what should I say, this knee joint. Okay, this curve, that is more extension 10 degrees beyond the neutral position. Okay, 1 point here, 1 point here, and 1 point that is for your spine. Put your hand, put your palm straight to the floor by keeping your legs straight. Okay, if the patient cannot bend his legs straight, can put his palms both on the floor, this is Beighton score, that is positive, and for this you will give 1 number. Okay, now see here, 2 2 2 2, it becomes total scoring is what? 1 2 3 4 5 6 7 8, and 1 score for this one, that is 9. Okay, if the score 4 is positive, it means the Beighton score that is positive and this patient is hypermobile. Okay, this is, what is this condition? That is flat foot. Okay, any child, if they give you a picture of the flat foot, we have to consider, is the weight decrease of this patient? Is there any sign that is telling me this is, there is problem in the muscle, there is problem in the joint? Just we can appreciate there is flat foot. This is flat foot that is present, but the weight of the patient seems to be very normal. Okay, most likely this is, most likely just on this picture, I can say this is not a case of, like if we talk about the hypermobility, this what are the differential diagnosis of the hypermobility? That is your Marfan syndrome, that is your Ehlers-Danlos syndrome. Okay, so please do tell me why this is not a case of Ehlers-Danlos syndrome, just on the basis of this picture that has showed me this pes planus flat foot that is present. Okay, and the hypermobility scoring that is positive, like Beighton score that is 5. But what are the signs which are not present here? I will not assign this is a case of Ehlers-Danlos syndrome. Skin number 1. See here, skin laxity that is not present, number 1 point. Number 2, bruises are not present. If the same picture that is present and they have shown me some bruises here and here and here, and skin is like wrinkled or lax, just pes planus that is present, they have mentioned, yeah, I will tell the examiner Beighton score is this much, like maybe 5 out of 9. So if bruises are present, you will describe this is a case of Ehlers-Danlos syndrome. Okay. This picture, now see the extension at the elbow joint. It is more than 10 degree beyond the neutral position. Okay, that is more extended. That is more extended. Okay. Okay. All right. The same. See here. This is also more extended. Here, there is lifting of the foot of the patient from the bed. This is the same picture. Beyond 90 degree, there is flexion. Straight line that is going a little beyond from the neutral 90 degrees. Okay. Okay, all right. So this is the joint hypermobility. You have this is one of the favorite questions of the MRCPCH exam. You must know what is the Beighton score, and you should apply this Beighton score on your patient. Okay. Now see here, I will just give place palm on the ground, standing with the legs straight. This is very important point, with the legs straight. Okay. That is important, right? Put your palms on the sole, on the ground. Yes, that is normal. But if you do not tell your patient, put your legs straight. This is the basically point to see hypermobility present or not. Okay. Extend your finger joint more than 90 degrees. Oppose thumb to the forearm. Extend your elbow. Extend your knee. Total 9 points. If we get more than 4, this is a Beighton score that is positive. The next thing is that we have to decide, okay, what scenarios you may get to make a diagnosis of the hypermobility. Generalized arthralgias, they are present most commonly anterior knee pain. Okay. That is most likely when starting or stopping exercise. Okay. After exercise, the patient will be tired, but otherwise the patient will be quite normal. Swimming is good, the child is doing well. Ida, go back, go back. Okay, sorry. Okay, difficulty with gripping, that is with if there is positivity in the fifth small finger or in the thumb. Okay, delayed walking, that is present. So this is the scenario you may get for your generalized hypermobility. Just we have to make differential of the Ehlers-Danlos syndrome or Marfan syndrome. Okay, in the Ehlers-Danlos syndrome, what is important? That is bruising that is present. Where you will go for echocardiography, these patients may come to you with a mitral valve prolapse. Okay, same is the case if there is hypermobility joint, the patient is tall statured, okay, having arachnodactyly, that is positive. Okay, so you should know how to make a diagnosis of the Marfan syndrome. What are the typical features? Tall statures, he must be wearing some spectacles. There is, what are the eye problems in the Marfan syndrome? There is lens dislocation. The child is coming to you with the spectacles. Okay, scar, bruise, yes, lens dislocation.
Esophageal lentis.
Okay, yes. Okay, all right. So like these are the points you must know and give a reading to these points. Okay, so this was the topic for today's discussion. I just wanted to tell you, you will give a reading to these two books at least before going to present any history, any clinical station. Okay, this is the picture that is basically showing leg length discrepancy. Okay, okay. Okay, any idea about the leg length discrepancy? What is this? This I have taken from the clinical MRCPCH book, that is Hamesh Palace. Okay, I have sent a soft copy of this book too. So see here, this is basically the method for the measurement of the leg length. This is the anterior superior iliac spine and this is the medial malleolus. Okay, you will measure the actual leg length and you will also measure what is the apparent leg length. Okay, this is very important. Leg length discrepancy in case of arthritis, In case of hypertrophy, in case of even DDH, one leg will be short and one leg will be long. Okay, so usually in the exam we do not get much time to measure this leg length, but please do remember, you must know how to check leg length discrepancy. Okay, from the anterior superior iliac spine to the medial malleolus, that is the apparent leg length. From the anterior superior iliac spine, you will measure this to the medial malleolus, that is the actual leg length. Okay, measure from the right side, measure from the left side. If there is the difference of some centimeters, maybe of 2 centimeters, maybe of 1 centimeter, like if that is coming 70 here or 73 here, this is leg length discrepancy. But please do remember, what is leg length? When there is real difference in the apparent and in actual both. If there is just difference in the apparent leg length, but the actual leg length that is normal on this side, there is no leg length discrepancy. Only and only when is difference there is in the apparent and in the actual leg length, then this is the leg length that is having discrepancy. There is difference in the length of the both legs. Clear? Is this clear? If not clear, please do tell me. Mariam, Dr. Arifa, how to measure apparent? See here, Dr. Arifa. This is pubic symphysis. Okay, this is, you will measure, you will put measuring tape over the pubic symphysis, then you will take it down to the medial malleolus. This is apparent leg length. What is the actual? From the anterior superior iliac spine towards the medial malleolus. Okay. Okay, all right. So this was all about today's discussion. Any question up till now? Is okay, clear? Okay, thank you. With this, I will finish my today's class. Tomorrow, there will be presentation of the history on the chest pain by Dr. Arifa. She will present the case. She will present us the history. Okay, all right. Okay, Dr. Arifa, please do a reading from the Smart PT. Also read these like from your Reham's notes and make your own notes. Okay, thank you so much. Allah Hafiz.